Greetings and welcome to another session of Montgomery Heart and Live. We apparently have some error with my clock on my StreamYard, and so it's giving me a different go live time. So I'm coming on probably 4 minutes early with some of my viewers on some of my streams, and some of my streams I'm a little bit late. And I think the clock is off. So I apologize if you're missing this. It's all recorded. So we are 4 minutes, probably 3 minutes early on YouTube. But anyway, we're talking about cardiac tests today. And the issue is cardiac tests and what do they mean. I'm going to be going through a lot of cardiac tests. Many of you may have had an evaluation by a cardiologist, and you may have had a number of tests ordered: EKG, stress tests, echoes, cardiac CT scans. And a number of individuals have posted questions about cardiac tests, have asked me to do shows on cardiac tests. So tonight we're going to cover cardiac tests. I think it's an important topic to cover. And so this is going to be the main topic and give an overview. And I think you should get a lot out of this. I'm going to talk about the importance of each test. And more importantly, toward the end, I'm going to give you insights in terms of important questions you need to ask your physicians if you are ordered, a test has been ordered, and understand the importance of potential risk and benefits of each test. So it's going to be very important. But before I get to that, what I want to do is share with you a couple of points, because oftentimes I get questions in the comments about how do I get started. Many of you ask me specific questions in terms of, what about this issue, or should I take this medication, etc. So I want to give you a few pointers, and all of this information is in the description below, and it's about how to get started on your journey. We have lots of valuable information on our website. However, going to our website can sometimes be a little bit confusing. It's very busy. And so the first step, I think, would be to order my book. If you haven't had a chance to order my book, The Food Prescription for Better Health, it has a lot of information about my philosophy. And I've had a number of individuals, one patient in particular I know, who flew into our center. He had ordered the book and followed the instructions in the book, the recipes, and he had significant improvement in his health condition even prior to seeing it. So the book has a lot of good information. So I think that would be a good place to start. Many of you often want to ask me questions. You have specific questions about health issues, etc. A good place to start would be to join our community. We have an online community. It's just $19 a month. You get monthly access to me, but also invite lots of like-minded physicians and other professional scientists and lifestyle experts. And so that's a well worth program, a community, to get closer into our community. You can also schedule an assessment call. That's very valuable. And again, the links of all these things are in our description below. If you order the assessment call, you can go and talk to one of our non-clinical members, and they can give you insight into all of our programs and share with you what program is best for you. They won't do a clinical assessment, but they can share with you the program is best for you. And of course, you can call our office if you need to make an appointment with us. And last but not least, Heart and Soul of a Champion. It's a docu-series that we have. It's very entertaining, and it gives a more in-depth look at what we do. We have season 1 out with Athletes Edition. We brought in some athletes with different chronic illnesses, and we chronicle their journeys through our lifestyle intervention program. So you can get a lot out of that. Season 2 may be released by the end of this year. That's chronic illness in women. I'll keep you posted on that. So anyway, without further ado, what about cardiac tests? So when your cardiologist or your doctor in general, and a lot of these things can be applied to any kind of medical evaluation. The overview, the start of any evaluation, is you want to find out what's going on with the patient. That consists of a conversation. We call it a history of the physical exam. But when I see patients that come in, I talk to them, and I essentially say, well, what brings you here today? What are some of your health concerns? And I let them tell the story. It's very important to me. One, to get to know who they are. It gives me information about who they are. And it's very important in terms of getting information. In fact, 85 to 95% of the time, I can get information from them by just talking to them. The history and physical is very important. The next approach would be to, in general, find out what's happening in and around the cells of their body. Now, I'm going to go through the details of how we do that. This consists of blood tests primarily. We also try to evaluate the function of the heart. And so that's another series of tests that we'll talk about. The next layer of information we try to get in an assessment is we try to get an evaluation of the function of the vascular system. How do the blood vessels work? And then we get some assessment of related organs. I list the kidney and liver here, but you also get information about the brain if they come in and have brain fog. The heart affects lots of organs in the body. The liver and the kidney are two main organs. So if there's evidence of liver congestion in someone with heart failure, we know that that's significant heart failure with congestion. That problem has been prolonged for a certain period of time, and we know that the liver function gets better as the heart function improves. We know that that's a sign that we're doing the right thing with the heart function. Similarly with the kidney. So we'll talk about that. So let's start off with the blood tests that we will order. So the first types of blood tests we get blood tests that look at the metabolic state of the body. This consists of lipids and lipoproteins. We also look at insulin and glucose levels. This gives information in terms of how the liver's working, how the muscles are working. If the person has lots of insulin resistance, the insulin levels are elevated, the blood sugar is elevated. Not only these abnormal numbers can be associated with problems with, say, not only the immune system, but the blood vessels, like insulin acts as a growth hormone. So if someone's had elevated insulin for a long time, we know that the heart may be thick and stiff. We know that the blood vessels may be stiff. And so this can give us an idea as to what's been happening to the cardiovascular system just by looking at these blood tests. It's an indirect way of looking at it. Other types of blood tests we look at, it gives us an idea of the condition of the heart muscle. There's a test called ultra-sensitive troponin levels. Now, many of you, if you've gone to emergency room with chest pain, they draw blood tests. They'll do a series of 3. They're looking at troponin levels. In the outpatient setting, we look at ultra-sensitive troponin levels. So if the ultra-sensitive troponin levels, it's 1,000 times more sensitive than what they tend to get in most emergency rooms. If the ultra-sensitive levels are elevated, we know that there's probably some stress on the heart. You're probably not having a heart attack, but there's some increased stress on the heart muscle cells, and we need to do some things to relieve that stress. BNP, or brain natriuretic peptide, is called brain natriuretic peptide because this was originally discovered in brain tissue. However, we've found that it's very much released in other parts of the body, such as the heart, the GI tract, and the like. And so we know that heart muscle that's stretched and that is under stress will release brain natriuretic peptides. If these levels are elevated, that's another sign of the heart being under stress. And that's a marker that we often look at to say, well, hey, this person may be in heart failure, and we'll do other tests to confirm that. Blood vessels, markers of the blood vessels, ADMA and SDMA. These are blood tests we look at that tells whether the inner lining of the blood vessels are healthy. If these numbers are elevated, then that's a sign that the endothelial cells are not producing adequate amounts of nitric oxide. And because of that, they're not very healthy. And so we can look at our treatment, various form of treatment, whether it's nutrition or some kind of medical or other natural intervention, and we see these numbers are coming down, we know that the blood vessels are getting healthy as a result of our treatment. And then other important markers such as C-reactive protein and myeloperoxidase, they measure the amount of inflammation in the body. You hear me talk a lot about inflammation. And we look at inflammation a lot in our patients, because if the inflammation level is high, that puts them at increased risk of an acute exacerbation of any health condition. It could be a heart attack. It could be decompensated heart failure. It could be decompensated chronic lung disease or arthritis. So increased inflammation can certainly lead to an acute event. And so you want to look at that. So the blood test gives us an idea of what's happening at the cellular level, at the biochemistry. No test is perfect, of course, but it gives us that type of information that we add to our pool of data. Now, what are some of the other types of tests? First of all, we do electrical testing of the heart. Many of you are familiar with the EKG. Sometimes people are confused whether it's EKG or ECG. Both are correct. The K comes from, the EKG was used in Europe and Germany. It was a cardiogram spelled with a K. So that's probably the origin there. But the EKG detects and measures electrical signals from the heart. So you put these electrodes on the chest. And of course, we're electrical beings. And so the heart is no different. And it sends out electrical tests. And it provides information about the function and structure of the heart. So if someone's had a heart attack, there may be a certain pattern on the EKG that we'll see that shows an old heart attack. It may be moving fast or an abnormal rhythm. So it gives us some information. How about cardiac monitoring? Cardiac monitoring is important because, you go about your day and you're, exercising, you're sleeping, or you're doing various things. And individuals may have certain symptoms. They may have shortness of breath. They may have other types of symptoms that contribute to symptoms like palpitations, chest pain, etc. We may put a monitor on, and while you're having these symptoms, we'll say, okay, what's happening with the heart? I've diagnosed arrhythmias, atrial fibrillation. I've diagnosed patients who are having, who've had coronary disease. They have ischemia, and they have ST segment abnormalities on the monitor. And so we can pick those things up. So it gives us the ability to monitor the heart when you're away from the office, because oftentimes you may get an EKG, nothing's happening. But when you're away, you're playing golf, you're at work, or whatever, you may go into an arrhythmia. Or you may have symptoms of your heart skipping beats or doing something like that, but the EKG is normal. That's information too, because that tells you that the symptoms that you're having are not related to a heart rhythm abnormality. So cardiac monitoring is pretty good. So what do some of these things look like? Here's a basic electrocardiogram. Now, teaching you electrocardiography is beyond the scope of this talk. However, notice my arrow here, you get a small bump and a spike right here and a hump after that. Bump, spike, hump. Now, this is one lead, so look at one part of the body. And notice you get a bump, spike, hump, bump, spike, hump. Each bump, spike, hump represents one cardiac cycle. So that's one beat of the heart. So I know that the closer these are together, the faster the heartbeat is. The farther these are apart, the slower the heartbeat is. So those are two simple things that you can look at and say, okay, that's something that we can talk about. Different parts of this EKG looks at different parts of the heart. I'm not going to belabor this point, but this looks at the front of the left ventricle. This looks sort of at the lateral side, the apex. This one, an AVL, looks at the high lateral part, and this looks at the bottom or inferior part of the heart. So we can say if there's something happening with the right coronary artery, we may see some changes here, as opposed to the LAD, maybe here. The circumflex may look at these leads and so on. So we get some idea of what's happening with the heart. Oftentimes the circumflex is hidden because that's more in the back of the heart, so the 12 lead won't show that, but sometimes you can see it in the high lateral leads, depending on how they're positioned. Now here's another diagram. So the P wave, this first little bump, that represents electrical activity in the upper chambers. So when I see some change here, I know there's something happening in the upper chamber. Then when it gets to this little filter here, we call that the AV node, you have a pause. And that's important because this little filter, God designed it to keep abnormal rhythms here, like atrial fibrillation, from going down and causing ventricular fibrillation. And so this pause acts like a breaker, a filter. It keeps excessive amount of electrical activity from the upper chamber, protects the lower chamber from that excessive electricity. So it goes through here, and then it goes down this conduction system. We call these bundle branches, or the His-Purkinje system. That's when you get the spike. Now, this spike is bigger than the hump because there's more muscle tissue in the lower chambers than there in the upper chambers. So it gives a bigger electrical signal. And then it repolarizes. That's just when we call that electrical recovery. So when it repolarizes or recovers electrically, we know that that's when you get the T wave. And so that's your cycle. This is one beat, and it recovers and starts over another beat. So here you got a normal rhythm. It's faster. See how these are closer together than these? Here's slower. These are farther apart than these, and same thing here. And this is irregular. These are close, these are far, these are close, etc. So this is probably a PAC. So it gives you an idea of what we look at when we're looking at a 12-lead EKG. And what about cardiac monitoring? Many of you may have had a cardiac monitor before. The monitor is very simple. They used to be large, little boxes you carry on your waistband and electrodes. Now they're these little Band-Aid-like devices, and we use these quite a bit. You can see how it compares to the size of a quarter. This fits underneath your shirt or your blouse or dress, and you can't see it too well. And so this works very well. You can wear this for up to 3 weeks. You can take it off when you shower. That we give you extra stickies to reapply it. Some people get allergic reaction to this. We have hypoallergenic versions of this. And so most people tolerate it very well. We have these implantable loop recorders. So these we can put underneath the skin. And I've used these a number of times before, and the battery of these lasts up to around 4 years. This is important for someone who has episodes of arrhythmias that's very rare, or arrhythmias that have been difficult to treat or diagnose, I should say. Or in some cases, my patients who have atrial fibrillation, and we think we've controlled the arrhythmia with diet and drugs, and they go long periods of time without any atrial fibrillation and all the other associated illness under control, we may take them off an anticoagulation with this. So here's a diagram showing you how it's placed underneath the skin. And here's where it sits underneath the skin. You have like a little suture line there. And this is tolerated very well. People go about their business with these, and then we take them out after, say, 3 years after we've gotten all of our information. What about cardiac physiology? How does the heart and body works physiologically, and what do we do for that? Well, overview, first of all, stress test taking. Now, there's lots of information we get from a stress test. This is like a treadmill or bicycle stress test, so it's an exercise test with a 12-lead EKG on you. It gives information about heart rate and blood pressure change with exercise. It gives us information about heart rhythm changes. Some people say, well, when I exercise, my heart starts racing or start having skip beats. And so we can determine heart rhythm change with exercise. And also gives information about the general fitness of the patient and their functional status. That's all valuable information that we use. If the blood pressure of the patient goes up super high after about 2 minutes of exercise, that's important to know. It may start off normal, it may shoot up very high, and that's a hypertensive response to blood pressure. So all this information we factor in terms of how we will help the patient out, whether it's with medications, lifestyle, or other therapeutics. Hemodynamic testing. Simple blood pressure and heart rate is non-invasive, extremely important. I look at this when my patients come in. Before I walk and see the patient, I'd say the heart rate's 105. So why is the patient's heart rate so high? That's a question that comes to mind. If the blood pressure is high, the heart rate's high, they may have high adrenaline levels. Maybe the blood pressure is high, the blood pressure low, and the heart rate's high. Maybe they're dehydrated or anemic. If the blood pressure is very high, they may be in that abnormal arrhythmia. So even when I see this, I may ask my team to get a 12-lead EKG because I said, well, if the heart rate's at 110, 120, are they in sinus rhythm? And I'll go and check their pulse, of course, but we'll still get a 12-lead EKG, make sure it's no kind of arrhythmia. There's a test that looks at thoracic impedance. It gives us information about the circulation of the heart. And also, this is an invasive test called a right heart catheterization. And it gives us information about pressure on the right side of the heart and circulation of the heart. And of course, vascular response testing. So there's an endopat test we use in the office, looks at endothelial function. Now remember, there's a blood test that looks at that, the ADMA and SDMA. So let's say the ADMA is elevated, and then we do an endopat test. It's abnormal. That's two tests that confirms that there's abnormal endothelial function. So even if there's no evidence of blockage somewhere, like on a CT angiogram or whatever, we know this person has heart disease because the endothelium is diseased. Carotid sinus massage, we'll rub on the neck, and we can elicit different changes in the EKG just by massaging the neck. And people have a hypersensitive carotid sinus. And a tilt table test, this looks at central nervous system and the cardiovascular system interaction. This is not done a lot in most cardiologists' office. We do some when we're looking at patients who have either POTS syndrome or syncopal episodes that we think is neurocardiogenic, and we will do a tilt table test to evaluate and confirm it is what we think it is, and we'll start treatment. So let's look at how the setup looks at. Many of you may have seen this before. Here's a gentleman on the treadmill. He has 12 lead electrodes hooked up, and there's the 12 leads of technician monitoring. There's a blood pressure cuff there every 2 minutes, or each 2 minutes, each 3 minute cycle of blood pressure is taken. And we get the heart rate and blood pressure. Now here's simple vital signs here. I mentioned before, blood pressure, heart rate, very, very important information to have. Even just simple vital signs. This is the thoracic impedance device. You have these electrodes that are here on the chest and up on the neck, and it measures shifts in fluid up in the thoracic area, in the chest area, and it does special calculations to give us information in terms of circulation. If we're in the hospital, we may do a more invasive study where this is little catheter here, this little plastic tube is what we call it. We call it a Swan-Ganz catheter, a right heart catheter. You see this little syringe injects air. There's a little balloon that inflates over here. So once you get it inside the vein and get it up to the heart, you can inflate the balloon, and then the flow of the heart will take it up to where it needs to go. So here's a diagram. You can insert this catheter from the groin. So typically we'll float it up through the IVC or inferior vena cava up to the right atrium, then into the right ventricle. We'll inflate the balloon, and then the flow of blood will take it up to the pulmonary arteries. And this is where we measure the pressures. We can wedge it in there, get a wedge pressure, but this gives us important information in terms of the hemodynamics and circulation of the heart. You can put it in through the arm or through the neck. So there are different ways of inserting it, and here's a close-up of that diagram. Vascular stress test, I mentioned carotid sinus massage. So you can massage the neck, and sometimes that can cause change in the rhythm. So if you look here, there's a 1-to-1 beat. See, this is normal. And when you massage the neck, it goes from normal, and then all of a sudden, look here, no more spikes. But you see little bumps. That means there's a conduction block from the upper to the lower chamber when you massage the neck. And this could explain why someone's passing out when they turn the neck from side to side or up or down. And so that's an important test you can do. And here's a vascular response test. We look at endothelial function here. And this is the setup. You got probes on 2 fingers, and it's measuring the vascular pulse wave. And then you inflate a cuff here. You block off flow to one of these, and then you leave that cuff inflated for a short period of time. And then when you deflate it, you see how it reacts. And so here's the cuff, the control arm. It has no blood cuff. And so there's flow continuously here. But in the cuff that you saw, like here with the arm, that's here. And so while the cuff is inflated, there's no flow. And when you release the pressure, what's normal, what should happen is that you get we call it a reactive hyperemia, but you get a hyper response because the flow has been set off, certain biochemical markers have been released, and you get increased vasodilation. This is normal. But if you don't get this hyper response, that means you have endothelial dysfunction. So the inner lining is not as healthy as you would want it to be. What about the physiology and anatomy? It's important to understand what's happening with the heart. Here's an echocardiogram. The probe is here, the right ventricle is here, the left ventricle is here, the aorta is here, and the left atrium is here. So we can get an ultrasound of the heart and get an idea of what's happening. Here are the walls of the left ventricle. They're pretty thick. There's fluid around the atrium. This is another view. It has mapped out left ventricle, left atrium, right ventricle, right atrium. There's fluid around here. So we get some anatomy. We can also measure pressure waveforms across here using Doppler signals, and it gives us some physiology as to what's happening in the heart itself. We can also look at the heart from the back. That's called a transesophageal echocardiogram. We pass a probe through your mouth, down your esophagus to the back of the heart, and you see this diagram here. Here's the diagram with the probe in the back. And so you're looking from the back side, and the left atrium sits the further back from the heart, and then the left ventricle. So you get a closer look at the valves and other areas. Also from the back, you're not having to bounce sound waves through ribs. And so sometimes people have suboptimal windows. And so we have to bounce sound waves through ribs. And here's the setup of the person lays on the side, and we pass a probe and we see what's happening with the heart there. So that's a transesophageal echo. Now, perfusion studies, many of you may have had a pharmacological stress test. We call it a nuclear stress oftentimes. Here's an example of a nuclear stress, and the different cuts. So we cut the heart in cross section, we cut it longitudinally, we also cut it lateral. And so we look at different walls. And so the top row here represents the stress, and this represents the rest. So if you give it a chemical agent to dilate the blood vessels, that's the stress image. So we'll take pictures after the resting phase first, and then stress will take second, usually, for pharmacological stress. Notice here, this bottom part here, that's the inferior wall. Notice it's not as clear, and it gets really bright here. It's a little bit cut off. You see it here, inferior wall, dull, and it gets brighter here. That means during stress, there's less flow here than during rest. We call that ischemia. You see a little bit here at the tip. It's not as bright, and see how it brightens up. That's at the apex, okay? And so that means you have ischemia in these parts of the heart. We also do what's called a PET scan. Different type of tracer. PET scans are good because in individuals, especially women who have large breasts or individuals that are big chested, you get a better penetration with PET scan. With the technetium, which is the other type of tracer, you may not pick up as much, and you get some artifact with that. And so sometimes we'll select the PET scan if we know that someone, it has a great chance of getting an artifact. So here on this one, this lateral wall, see how that's thin, and see it gets a bit brighter here. Okay, now it's bright. That's a sign of ischemia. This is stress, this is rest, and it gets better with rest and stress. That's better blood flow to rest. That means the arteries are not opening up adequately during stress. And so you can have that. Now, sometimes you can have what looks normal, and it can be due to a balance defect. So if you have two arteries that are diseased and they're equally compromised, the rest and stress may look the same because it's a balanced flow all the way throughout, because you're looking at a comparison of flow from this artery to that artery. But if both of these arteries are equally damaged, then the flow will look the same, and it may look normal from stress to rest. So you can get what's called a balance defect. Here's another obvious one. This is stress. Look how light that is. And with rest, it comes back. Better flow with rest compared to stress. Here, there's stress and rest look about the same. That's probably a scar. So ischemia, the stress looks worse than rest. With scar, the stress and rest are about the same. So that's how we tell whether the tissue is viable. So if we know you have coronary disease, we may do a perfusion study first, because let's say if we looked at, the artery in this one, and let's say you have disease in the LAD, but that's all scar, your cardiologist may choose not to revascularize this or bypass, because this doesn't look like it's viable. And so this helps us, this information plus the coronary angiogram helps us make a decision in terms of the treatment. Here's a picture of the coronary angiogram. You have the circumflex artery, you have the LAD here, you got the right coronary artery, and there are different angles of these arteries. And so this is where we look at the anatomy. This looks pretty normal. But a normal coronary angiogram does not mean that your coronary arteries are totally normal. We used to think of the coronary angiogram as the gold standard. It's not. You can have a 5 or 10% plaque somewhere along here that you don't see. And if you go in with ultrasound, you can see lots of plaque that you won't see with angiogram. So the angiogram is not a gold standard. People can get an angiogram and have a heart attack 2 weeks later, even though it may look normal. In fact, I had a patient looking at this artery here. I was called in the emergency room. Patient had a heart attack, classic EKG, classic symptoms. I rushed him to the cath lab. I shot a coronary angiogram. It looked like this, looked clear. What was the explanation? Well, he probably had a very small plaque that was, vulnerable, maybe 10%, 5%, and it ruptured. And so he had an unstable plaque that ruptured and a clot formed right where that rupture was. And the clot formed while the clot was there. There was obstruction, there was infarction. But sometimes the body's thrombolytic process can break the clot up fairly rapidly. And that's what happened in this situation. So it spontaneously dissolved the clot. By the time I shot my angiogram, there was nothing there. And so you can see that. So a normal angiogram, or what an angiogram that doesn't show any significant blockage, is not the gold standard. It doesn't guarantee that you don't have any significant coronary disease. And it doesn't guarantee that you can't have a problem. Now, this is an image of what we call a CT coronary angiogram. So this is where you can look at the coronary arteries less invasively. The other angiogram, you go to the hospital, you go to what's called a cath lab. They'll inject your arm or your groin and put a catheter up in your heart and inject your coronary arteries directly. Here, you go to an imaging center, oftentimes at a hospital. You get an IV here. And with the new technology with the CT scans, they can do special imaging and calculation to look at the contrast as it goes through the coronary arteries. You can also look at the calcium and do a calcium score calculation. So many of you may have had calcium scores, and so this is a part how to do it. I often order a calcium score and a coronary angiogram together. You can have a calcium score of 0 and still have significant coronary disease. I've had patients with a 0 calcium score but have a 50% unstable looking plaque. And so that person can have a 0 calcium score and be at risk for a heart attack. So again, no one test, totally tells a picture. Now, this is a test many of you may not know about, but because I'm an electrophysiologist and I've done thousands of these, I have to talk about it. This is an electrophysiology study. The electrophysiology study is a detailed look at the electrical system of the heart. So we put electrical catheters inside the heart. We normally go through a vein. This is in the high right atrium. This catheter comes in and it goes to the coronary sinus. This catheter goes into the His bundle, and this catheter goes into the right ventricle. Notice these little squares here. These are electrodes. So this is like taking an EKG from inside the heart. So you look at the surface electrodes, and up here, excuse me, this represents the electrodes that we have on the chest of the patient. And then starting here, this represents the electrodes we have inside the heart. And notice how these spikes are sharper. Because they're inside the heart, they're getting more direct electrical signal from in the heart. And so not only that, I can pace the heart from here, I can pace it here, and I can do certain pacing manipulations to try to trip the heart up and put it in an abnormal rhythm. And this is what we call electrophysiology study. We can measure the conduction from the ventricle back to the atrium. We can measure conduction from the atrium to the ventricle and in other parts of the heart. So this gives us important detailed information. The atrium, His bundle, ventricle. It gives detailed information in terms of electrical signals. And we can also detect arrhythmias by inducing arrhythmias. If we induce an arrhythmia, then we can go in with a therapeutic catheter and ablate that arrhythmia. And some of these arrhythmias can be cured. So electrophysiology study is a very important study. Here's a setup in the cath lab. I've done lots of these. These guys have to be doing an AFib ablation. Maybe you heard of that probably. And here you see the 3D mapping where my arrow is. And then you see the intracardiac electrograms here. and then you see the fluoroscopy here. So the operators have a good idea. They can tell where the catheters are based on electrical signal they're getting. They can also tell by the 3D mapping and also the fluoroscopy or X-ray images they have too. So there's a lot of information you're getting. And while you're doing these complex procedures, you're putting lots of information together. Now, I knew I gave you quite a bit of information. There's the other tests that I didn't talk about, cardiac MRI, various things. If you want to learn more about some of these tests, feel free to, ask in the comment section because I think, we like to hear from you. I want to know what you want to hear about. And the reason I'm doing this talk is because lots of people, talked about, or asked me to talk about cardiac tests. So what are the summary remarks? Oftentimes you refer to a cardiologist, they're recommending different tests. What do you want to know? One, realize that there's no one test that's perfect. Oftentimes we put together information from a number of different tests. So you may say, okay, your stress test is abnormal. We need to take you to the hospital and do a heart cath, put a stent in. Well, it may be abnormal, but does it mean you have to have a stent? Not necessarily. So you want to ask other questions. Multiple tests can work together to give you information. You also have testing in general that you should have a purpose behind it. Let's say you're asymptomatic, you're fairly healthy, you go get a regular checkup, you do a stress test, the stress test is abnormal. It's, well, you need to see a cardiologist, well, we need to take you to the cath lab and do a stent. Well, wait a minute, what are we trying to achieve here? Is there an urgency to do that? Are there other options? And so on. If you're not given other options, you need to maybe pause and maybe get a second or third opinion because you always want to have a purpose. If you're relatively healthy, you're not in acute danger. Yeah, if you have an abnormal stress test, that may mean you have coronary disease. Well, what else can you do other than put a stent in? Maybe there's lifestyle changes or medication, whatever. Maybe if your cholesterol's high, you can get it down. If your inflammation's high, you can get it down. So there are other types of things that you can look at. Your ADMA, some of the blood tests may be marked and saying, well, look, your endothelial cells are unhealthy, your cholesterol's high, you have inflammation, and the stress test abnormal. You feel fine, but you need to make aggressive lifestyle changes. So you make aggressive lifestyle changes, these blood tests start to normalize. That's a clue that other things may be getting better. So you don't always have to do something invasive. So yes, sometimes it's important, it's beneficial, but just make sure you understand the risks and benefits of any test you're doing and understand the overall objectives. So I think that's going to be the most important thing is to understand the overall objectives because you really want to the purpose of getting any evaluation is A, understanding your level of health, and B, addressing any problem that you may find, but it doesn't always mean that you need a pill or procedure or something like that. It just may mean that you just need to make some lifestyle changes and then you can follow those changes over time. Real quick, for those of you at the very beginning, I started telling you about how to get started. And in the rush, I didn't have my slides up. I'm just going to quickly go through these again. All this information is in the description. But if you have questions about my philosophy, get the book. Read the book, The Food Prescription for Better Health. It's on Amazon. Here's a link. The link is in the description. That's what the book looks like. If you want to talk to me directly, join our community. There are probably community members in the chat so they can share with you their experience. But you can go on to our website, MontgomeryHeart.com/journey. Again, that link is in the description. You can schedule a free general assessment call. One of our team members will be there, and they can, it's a group call, but you can get information about our programs. You're free to share some of your health concerns, and that group member can direct you in the right place in terms of what can work best for you. Step 4, call for an appointment. We see patients from all over the country, have international patients. So give us a call, and depending on what your illness is, and if you have some acute illness, we will try to work you in. We have a waiting list, but we'll try to work in sooner if you need to be seen sooner. And last but not least, Heart and Soul of a Champion is a docu-series we have. There's a link here. This is season 1, Athletes Edition. It shows how we've taken some athletes who at one time were in their prime, they're in their 50s and 60s. They're coming, they're working out, and many of them are diagnosed with health conditions that we then work through, and it gives you an in-depth look at how individuals go through our program. So just thought I'd share that with you because I did not have my slides up at the beginning. I had my internet worked on, so it threw the clock off on my timer here. So I started early on some platforms and later on others. Anyway, so I hope that was helpful for you. Again, always leave questions in the comment section. And of course, any questions you have in any show ideas, please leave that in the comment section. We do read that. Although I can't answer all the questions, but if you have a question you want to talk to me directly, join the community, MontgomeryHeart.com/community or /journey, or buy the book, or do all the above. And we look forward to seeing you. So if you're new to the channel, of course, please subscribe. And then, of course, give us the thumbs up, like, and share this important information with any and everyone you know can benefit. Until next time, take care.